I am Susan Spinoza, a co-founder of the NTRKers organization, and also a thyroid cancer NTRK patient myself. The NTRKers is a growing nonprofit organization to unite and support people affected by N-Trac gene fusion cancer. We collaborate with medical experts and other cancer groups to raise awareness, support research, diagnosis, and testing, and also the overall education in the community. You can find us at online at ntrackers.org, which is our website. Email is info@ntrackers.org. We're also on Twitter and Facebook, the N-Trac support group. I want to thank everyone for their time today. We are very excited to have Jay Scott, the Executive Director of the Alex Lemonade Foundation, along with 3 brilliant doctors, all who have volunteered their precious time to be with us today. And now I'm going to hand it over to Jay, who will be moderating today's webinar.
Thank you, Susan. And I just want to welcome everybody to the webinar today. We appreciate you joining us. Some housekeeping issues. If you have questions for the speakers, you can submit them through the chat function. Just click on chat and then send the question in, and we will take care of them at the end of each session. We're going to do questions at the end of each session, and then we're going to have a panel discussion at the end where you'll have another chance to ask questions. I've moderated many webinars, but I've never moderated one with this many moving parts. So I hope I hope we get through it all right. Be patient with me. We have some amazing speakers here today. We have 4 NTRKers. You heard from Susan, who's the president and a patient survivor. We have Kaylee Leeds, who's a parent advocate. We have Miranda Bowman, who's also a parent advocate, and Leslie Markham, another parent advocate. And then we have 3 clinical speakers. We have Dr. Cornelis Van Tilburg, who is the senior physician of pediatric oncology and hematology at Hopp Children's Cancer Center in Heidelberg, Germany. We have Dr. Alberto Pappo, the director of the Solid Tumor Division and co-leader of Developmental Biology in the Solid Tumor Program at St. Jude Children's Research Hospital. And we have Professor Stephen Wagospack. He's a professor in the Department of Endocrine and Neoplasia and Hormonal Disorders at MD Anderson in Houston. So we have a great lineup. We're looking forward to sharing it with you, and we're going to get started right now and hear from a parent advocate, Miranda Bowman.
Hi, everyone. As you said, my name is Miranda Bowman. I am a parent of Hunter Bowman. He is 16 now, but he was first diagnosed with thyroid cancer at 9 years old in January of 2014. And I wish in January of 2014 that we had had a group like NTRKers, because Hunter had, first he had surgery and he had radioiodine treatment. He had already had metastatic disease through his neck, lymph nodes, and in his lungs. But we were told, even so, it was an easy, treatable cancer. But that proved to be far from the truth. Hunter was first treated at a local children's hospital, and after standard treatment, his tumors continued to grow, the lung tumors continued to grow, and the doctors kind of said, we really don't know why this is happening. I've never seen this before. They sent us to a bigger university hospital where he had another surgery, another round of radioactive iodine treatment, and again, we were told, it's still growing. We don't know why. We have done everything we can, and we don't know what else to do. So, maybe look into some trials. And so I started really researching, and I found out the best doctor and the best cancer hospital for thyroid cancer through THYCA, which is a nonprofit for thyroid cancer. That MD Anderson was the place to go. And so I started working on getting Hunter into MD Anderson. I made phone calls, I emailed, I talked to every THYCA mom, thyroid cancer mom, every thyroid cancer survivor who had persistent progressive disease. And I finally got him into that hospital where for the first, I think the first time he went was in 2016. And at his first appointment, his Dr. Waguespack, who's here today, he said, okay, we're going to do this biomarker testing, which I had never heard of. And so he was like, there's this trial going on for this TRK fusion. It's unlikely that Hunter has it, but we're going to test him for it anyway. There's very few pediatric cases, very few cases in general, but we're going to test him for it. And I also met Sandra, who's here as well. Sandra was our coordinator and got him all set up and was not expecting anything. And then I got a phone call very soon. They told me it would be 6 weeks or something. And it was within a few weeks, they called me and said he was positive. So this was really good news. We finally knew what was driving his cancer. We finally knew there's other options for him. And so Hunter started on a clinical trial and of a medication that targets N-Trac fusions, and he did phenomenally well. He did so well and had such a good response. But it was such a journey getting there, and it was so much that I had to do as a parent to research and find out, because it was such an unknown thing at the time. So Hunter is doing extremely well right now. He is 16, he is 6'2", he is just doing everything that a 16-year-old should and would want to do. And we are so thankful for the research going into this type of tumor marker, and we're so thankful for the NTRKer group. And I'm so excited for the parents coming after me who have the opportunity to find out the information that I wish I had had before. Thank you, everyone. And I think Jay is going to take over again.
Thanks, Miranda. Thanks for sharing your story. We appreciate it. The first clinical speaker we have, the way this is going to work is we're going to have 2-minute stories from parent advocates, and then we're going to have about 10-minute presentations from our clinical speakers, followed by questions. And our first speaker is Dr. Cornelis Van Tilburg from Heidelberg. Dr. Van Tilburg is responsible for the care of pediatric brain tumor patients and the development of clinical trials at KiTZ. In Inform, which is individualized therapy for relapsed malignancies in childhood, the largest transnational genome sequencing program for children with cancer in Europe, Dr. Van Tilburg's role involves translating molecular findings from the registry into biomarker-driven clinical trials with the hope of offering children with progressive or relapsed cancers a second chance. With that, I'll turn it over to Dr. Van Tilburg.
Well, thank you very much, Jay. It's a very nice introduction, very kind of you, thank you. So today I will focus on N-Trac fusions and brain tumors. This is the agenda, but we can go through it to the next slide. I will first briefly explain what N-Trac fusions actually are, because I'm not sure everybody in the public knows exactly what those are, and then we'll go into the brain tumors. So in a normal situation, you have this TRK, tropomyosin receptor kinase, which are primarily located in the nervous system. It's a normal protein action, actually, and at the second bullet, you can see its normal actions. So we have N-Trac 1, 2, 3, which stands for TRK ABC, which is involved in pain, temperature regulation, movement, memory, mood, appetite, body weight, and sense of body position. Those are the normal functions of TRK. And normally, TRK is regulated as depicted here. You have normal regulated of your TRK, and in those tissues, TRK is expressed, the protein is there, it's used, but it's being regulated by normal regulation. Maybe this is a nice picture for that. But in the case of a fusion, there's some other kind of fusion partner before the TRK kinase domain. So somebody else is sitting in the driver's seat, so to say. And TRK is being activated in places where it shouldn't be activated, depicted here. And what's even worse, this cannot be changed. So this regulation of TRK is fixed. If you put for the next, the this fusion, so to say, becomes an oncogenic driver which can be stopped. So the car is in gear and will stay in gear. Next slide. Okay, there was some other animation, but yeah, so the car stays in gear, and that's called an oncogenic driver, which is, I think, a rather good analog. Yeah, it's there. But we can go to the next slide. So where are N-Trac fusions occurring? In the left picture, you can see the adults, but we are focusing on children now. And in children, every cancer actually is a rare disease, but still we make a difference between, in green, the rare tumors with high TRK frequency, and the blue, common tumors with low N-Trac gene fusion frequency. And this is a little bit strange, but because actually there are no common tumors in pediatrics, but there are some tumors are more frequent than others, of course. But today we are actually only talking, in my talk at least, about the high-grade gliomas or gliomas, brain tumors. But the others are thyroid cancer, which will be also discussed today. Infantile fibrosarcoma, which is a rare tumor, but almost always with an N-Trac fusion, and there's also a kidney tumor and some sarcomas, which have N-Trac fusions. Next slide. Which N-Trac inhibitors are there at the moment? So there are actually 4: larotrectinib, entrectinib, zilitrectinib, and reprotrectinib. Larotrectinib and entrectinib were the first, and there are now second generations N-Trac inhibitors investigated in clinical trials, zilitrectinib and reprotrectinib. And they all, of course, inhibit N-Trac, but are also other kind of targets for entrectinib and reprotrectinib. The important thing about the second generation N-Trac inhibitors is that they all also cover so-called resistance mutations, which sometimes occur under first-line N-Trac inhibitor treatment. Both drugs are approved by the AMA and the FDA, but only entrectinib is only approved from the age of 12 years on. Next slide, please. We're first going to discuss larotrectinib now. Oh, sorry, we first have a case. This is a case which I didn't take because it was such a success. It is a case which I wanted to show you because it nicely explains where we are at this moment and things we don't know at the moment. This was a young girl, an infant girl with a glioma, a brain tumor. She received frontline chemotherapy, but after chemotherapy, she unfortunately progressed. Her N-Trac fusion was identified in the INFORM registry, and she received larotrectinib, whereon she stabilized. Unfortunately, she showed progression under larotrectinib, whereafter she became proton beam therapy. Again, after proton beam therapy, she progressed, and now we're here. She became a second line N-Trac inhibitor, zilitrectinib, 1.5 years ago. You see this large tumor here, which was formerly only so small, and she responded remarkably well to that. It was impressive radiologically, but also neurologically. She had a very good response. She really recovered. So we were all, of course, very happy. Unfortunately, there was a rapid progress under treatment, which even got further, and in the end, she unfortunately deceased under therapy treatment, which nicely explains that we have potent drugs, but we are not it's not completely clear how and when they work the best in brain tumors. Next slide. Next slide, please. Now about larotrectinib. One slide about the drug itself. This is a little bit technical, but I assume we will manage to go through it. There was in the study which was presented last year, there were 24 patients with brain tumors, and 29% of them responded, so roughly a third. And response is not always complete response; also partial responses are in there. Another important number is the disease control rate at 24 weeks, which was approximately 63%. And that's something we also saw in our patient, that we were able to stabilize the disease with larotrectinib, but she didn't really respond. Some kind of tumor shrinkage was seen in much more patients, as you can also see in this figure, which shows you the reduction of tumor volume in pediatric patients with different kind of diseases. Next slide, please. This is about entrectinib. Also, these are all kind of tumors, not only CNS tumors. If you click one slide further, you can see in the one click more, you can see that the yellow marked patients are pediatric brain tumors. And you can appreciate from the diagnosis that there are all kinds of pediatric brain tumors in there, but most of them responded quite well. Of course, the number of patients is rather low here, so you cannot compare 29% from the last slide with this 70%. That's not fair, but it's fair to say that both drugs have good activity against brain tumors. Next slide, please. Yes. Toxicity is, of course, important if you talk about new drugs. Side effects are here compared in this graph with an older drug, which also has some kind of N-Trac inhibition. But both new drugs are much more specific and stronger. And you can see that the larotrectinib and entrectinib have a lower amount of side effects compared with the old drug. But if you compare them, you still see that there are dose reductions necessary for entrectinib and larotrectinib, and also sometimes treatment discontinuation. So it's not the case that there are no side effects with both drugs, but they are well manageable. Next slide. Testing, of course, an important subject, because you need to have the N-Trac fusion to be able to respond to the drug. And my personal opinion is that all pediatric brain tumor patients deserve molecular testing. And that's not only important to fight N-Trac fusions. There are also other alterations which react very well to other drugs. So like the BRAF-V600E mutation, BRAF fusions in low-grade glioma. It's important to know these things. And in addition, there are now more molecular classifications possible in brain tumors, which also allow us to be more specific on prognosis of different tumors. The methods used are RNA sequencing, which is more precise compared to panel sequencing, but which can also be very fine, which is still better as FISH, which is more protein-based technique, antibody-based technique. Sorry. There's also immunohistochemistry, but this is not working in brain tumor tissue because the protein, TRAC protein, is expressed in brain tumor tissue, as I explained in my first slide. So it doesn't play a role in brain tumors. And the last bullet is, of course, important. N-Trac inhibition only works in patients with N-Trac fusions. Testing programs at the right panel. So in Germany, we have the INFORM registry, which includes high-grade glioma or relapsed patients. We have LOGIC-Core for low-grade gliomas. We have the MMP and PTT registries. And if you are interested, you can visit our website. The next slide are the challenges for brain tumors. So in brain tumors, it's important to consider the aspect of brain penetrations. Not all drugs which are in the blood penetrate the brain equally as they do in blood, so as in solid tumors. And this, of course, influences the needed dose. And it's not known if brain tumors require the same dosing as other tumors. Testing, I've just explained, plays an essential role, but it's not available everywhere yet. Resistance mutations are occurring, and it's not clear which stage they mostly occur, and of course you need molecular testing to detect them. Toxicity is an important aspect. I didn't go into that far, and I think that's enough for now also. I think that was my last slide, and I'm happy to take some questions. Jay, you're on mute.
Sorry about that. If anybody has questions, you can put it into the chat. We have one that just came in. Thank you very much for the interesting presentation. Regarding the case of infant glioma, what was the length of response on selatrectinib?
Yes, I think the response was approximately 2 to 4 months, so very brief. So there was a very rapid and very large response, but the tumor came back also quite fast.
And so if we don't get to your question, we will have them answered either in the panel discussion or after the meeting. So you can put the questions there and we will get to them. We're just trying to stay on track here. So I'm going to read another question here. When choosing a second-line drug, what determines which drug to choose? Are they the same or is one better? And they're talking about repotrectinib or selatrectinib.
Yes, that's a very good question, and I don't know the answer. They are both in a very early stage of development. They are both good drugs as far as I can see at this moment. Repotrectinib is a little bit lagging behind in clinical development, so there are not too many places where the clinical trial is open already, and not all age categories are open already. So that can be a practical reason not to not go there. But at this moment, I don't have a good clinical or scientific reason to go for one drug or the other, because there's no real data you can compare at the moment.
Thank you. Kathy Oliver says, thank you very much for all the work you do in this field, and it's much appreciated. And she's from the International Brain Tumor Alliance. I'm going to sneak in one more question, and it says, do you worry about elevated liver enzymes or cholesterol with these drugs?
So these side effects do occur, and you have to be aware of them, of course. But in my experience, they do not really lead to clinical problems, and dose reductions most of the time suffice to cover these problems. And yeah, and so in daily clinical practice, I don't think it's a big problem, but you of course have to be aware of them. You can't ignore them.
Well, that wraps up our questions. We'll hear from you again during the panel discussion, but we appreciate your presentation and all the work you do, Dr. Van Tilburg. And with that, we're going to move on and hear our next story for 2 minutes from Leslie Markham, who is Lakeland's mom.
Hi, guys. Can everyone hear me? Okay, great. So our story is a little bit different than Miranda and Hunter. Lakeland is now 7, but when this all started, she was 3, right after her 3rd birthday, and we noticed that she kept complaining about her right arm, and she would say there was a boo-boo in her arm. And as the days progressed, she'd wake up in the middle of the night crying and screaming that she had a boo-boo in her arm. So after a few weeks, we decided to go to the pediatrician. The pediatrician tested her strength, and she said she's fine. Maybe she doesn't want to sleep at night. As a 3-year-old, you know that if they're pointing to the same location, that is not necessarily the case. They're probably, at a 3 years old, you're going to point to other locations if you don't want to sleep at night. So me and her dad knew that there was something else going on. So a week goes by and she's still screaming at night that there's a boo-boo in her arm. And after that, we called the pediatrician and asked for an x-ray. The x-ray came back and it was fine. So again, there was no reason for why she was crying about pain. And then about a couple of weeks go by again, and she starts not using her arm as much. And with that, we knew something was wrong. So instinct of a parent just knows that something's not right. So we called and asked for a pediatric orthopedic surgeon consult. We couldn't get it for about a month. And so within that time frame, she went from a happy little girl to just crying all the time and not using her arm and holding her arm back and doing signs that were just different for us. She'd put a glove on her hand because things were sticky. And at the time, we didn't know what she was doing or why she was doing it. We went to the orthopedic surgeon and did a blood test. Nothing showed up in the blood. We asked for an MRI. And December of 2016, we had a MRI right after Christmas. And the MRI was supposed to take about an hour and a half, and ended up taking almost 5 hours. And so we knew something was wrong. The next day, we got a call saying that she had a mass on her brachial plexus. I didn't even know what a brachial plexus was. I didn't know what they were talking about, but it went from her C5 to her T1, and it was wrapped around her nerves. So that explained a lot of the pain that she was having. So we had to urgently go to UNC and get a biopsy and meet with the oncologist. And thankfully, our oncologist at the time was Dr. Blatt, and she knew that this was an odd location and the mass was just interesting and a challenging location. So we ended up getting the biopsy on January 10th of 2017. And we sent it out to tons of pathologists to take a look at it, and they couldn't really get a good picture. So everything kind of came back different. And that was a big challenge because nobody had the same review of it. But on that same day, she knew of Foundations 1. And so from day one of really visiting her, she chose to send, with our consent, send her scans and her biopsy to Foundations 1 to test for molecular test sequencing. That took 6 weeks. And at the time, a couple of years ago, insurance didn't pay for it. So we just agreed to it, didn't know what it was going to cost us. But she was an advocate for molecular sequencing. And thankfully, because of that, during that 6 week time, my mom and I did a ton of research to try to find a surgeon that could take a look at her brachial plexus and the tumor and how it was wrapped around the nerves. And there was one at Johns Hopkins. So we sent her scans and everything to Johns Hopkins. And that same week, a tumor board met, and the N-Trac, or not the N-Trac, the Foundations 1 sent the results to the board, the tumor board, and they reviewed it. And there was an oncologist there that knew of a clinical trial and said, this is our only hope to save your little girl, is to put her on this clinical trial for N-Trac fusion. So Boston got to us and said, if you can fly up, come up here tomorrow at, we have to be here at 3 o'clock. So we flew up the next day from North Carolina, met with the team, and she started a phase 1 N-Trac inhibitor clinical trial. And from that time frame, she, for 4 months, she saw great regression in her tumor. And she started with a lot of pain medicine and was able to start using her arm. So we saw beautiful results. But from that time frame, she became stable and she plateaued. And so the tumor hasn't grown or shrunk since. And so we gave her a holiday where we call it a holiday, where we took her off the drug for a short period of time to see if it was necrosis to the tissue, and maybe there was some dead tissue, that it wasn't active cancer. But within a couple of weeks, it grew bigger than its original size. And so we had to put her back on the clinical trial, and she had a great response. That was in October of 2018. And it shrunk for the first 2 months, and then it has stayed stable since then. The beautiful thing is that you would never see my daughter and look and think that she had cancer and the pain that she's gone through. But thankfully, from the oncologist, from day one, she hasn't had to try the standard forms of chemo and treatment. And so she has great movement and strength in her arm. We just take it day by day and use this inhibitor to keep her cancer stable, her disease state stable. the N-Trackers have been a phenomenal group for me because, as you can imagine, a 3-year-old, 4-year-old, 5-year-old has a hard time expressing what they feel. And I was able to kind of identify through other patients, adults and pediatrics, what she was going through and what her side effects were. So the challenges as a parent is just, this is an unknown field, and not knowing what our next step is going to be or when the change is going to happen. But we're grateful that we've had 57 cycles with an N-Trac inhibitor, and she's doing wonderfully. So this is a beautiful way of researching and figuring out a new way to treat pediatrics. So thank you. And back to you.
Thank you, Leslie. We're big fans of Lakeland here at Alex's Lemonade. So our next clinical speaker is Dr. Alberto Pappo. Dr. Pappo is world-renowned in clinical research of rare cancers and pediatric sarcomas. He's a director of the solid tumor division at St. Jude Children's Research Hospital and specializes in pediatric melanoma, soft tissue sarcomas, and pediatric GI stromal tumors. Prior to his role at St. Jude's, he was professor of hematology oncology at the Hospital for Sick Children in Toronto, and also professor of pediatrics at Texas Children's Hospital in Houston, Texas. He chairs the FDA's Pediatric Oncology Advisory Subcommittee on Oncologic Drugs. And with that, I will turn it over to Dr. Pappo.
Thank you very much, Jay. And Leslie, thank you very much for sharing your story. And that will lead us to some of the unanswered questions, like how long you continue this wonderful drug. So today I'm going to talk to you about N-Trac inhibition for pediatric soft tissue sarcomas. Next slide, please. So I think one of the things that I wanted to start with was how common is it to have an N-Trac fusion in different cancers? And this is a very nice review from an adult series over 38,000 samples. And in their series, they found that only about 0.2% of these tumors that were tested, this is a series from Memorial, had actually an N-Trac fusion. But if you look at the table over here, it's really highly dependent on the histology. For example, salivary gland carcinomas, which is something called MASC, mammary analog circulatory carcinoma, have a much higher incidence of these fusions compared to other cancers. Next slide, please. A similar study has been recently reported from CHOP, and they looked at 1,347 pediatric patients, and of those, 29 had an N-Trac fusion. So that accounted for about 2% of all of the tumors that were tested. And when you look at solid tumors, it accounted for about 3% of all of the solid tumors. And as you can see in the little table to the right, it's mostly restricted to 3 main groups: brain tumors, thyroid tumors, and soft tissue sarcomas, and rarely you can see them in other areas. It is also interesting that N-Trac2 fusions are usually seen in CNS tumors, and N-Trac1 fusions are usually seen in papillary thyroid carcinomas, whereas N-Trac3 fusions are seen all throughout. And this leads me to, next slide, please, to the concept of what is a molecular target. So it's basically a molecule in cells that is associated with a specific disease process. In this instance, for example, would be an N-Trac fusion. And it is believed that this specific molecule is responsible for progression and drug resistance, and that there is a target that you can use with a small molecule, in this case, for example, larotrectinib, that will produce an alteration in the disease process, ultimately would be disease regression or a complete response to the therapy. Next slide. And this also leads me to another important concept, which is the concept of tissue agnostic drugs. We have been talking about N-Trac, and we've seen that these alterations can be seen in a variety of different tumors, from leukemias to soft tissue tumors to thyroid tumors to brain tumors. And this leads me to the concept of agnostic drugs, which is a treatment that is effective against tumors with a specific genetic alteration regardless of the anatomic location. And that is what's not commonly described as a basket trial. That means that no matter what histology you have, if you have that specific alteration in N-Trac, whether it's N-Trac 1, 2, or 3, you are eligible to receive a specific drug. And the best known example is larotrectinib. So that is what tissue agnostic means. And that's what a basket trial is. Next slide, please. Next slide. So we're going to start with larotrectinib, and I'm going to summarize the evidence on patients less than 18 years of age with sarcomas that had an N-Trac fusion that were treated in 2 different clinical trials. The dose was 100 milligrams per meter square, and the endpoint was overall response using a specific criteria called RECIST 1.1. Next slide, please. So this slide summarizes the results of patients with soft tissue sarcomas. There were a total of 55 pediatric patients with soft tissue sarcomas. The vast majority of them had the most common type that we know, which is infantile fibrosarcoma. 21 of them had other types of soft tissue sarcomas. And that also raises the possibility of when do you test soft tissue sarcomas for N-Trac fusions, but we can leave that for the discussion. The vast majority of patients, about 55, were male. And then again, the most common histology was infantile fibrosarcoma. As you can see, there were multiple types of gene fusions, N-Trac 1, 2, and 3. There comes the issue of tissue agnostic. And as of July 15, 2019, there were 59 patients, 34 had infantile fibrosarcoma. Median age was relatively young, only 1.3 years. And about 30% of these patients had not received any prior therapy. Next slide, please. And this is the overall response rate. So it's amazing that 93% of these patients actually responded to the drug. And when you look at specifically for patients with infantile fibrosarcoma, the response rate is 100%. So this is something unprecedented for a single agent, for a drug that you can give by mouth with very minimal side effects. Next slide, please. There were some other efficacy endpoints that are important to highlight. One of them is, well, if you respond, for how long do you respond? And as you can see, at least for patients with infantile fibrosarcoma, 90% of patients were still responding 24 months after starting the drug. And about 2/3 of other soft tissue sarcomas were still responding 2 years after starting the drug. Progression-free survival means at the time that you develop a recurrence, what percentage of those patients are basically disease-free. And again, with infantile fibrosarcoma, almost 90% of them had never progressed. And the survival with infantile fibrosarcoma, at least 100% of these patients were alive, and 88% of patients with other sarcomas were alive while they were receiving this drug at 2 years. Next slide, please. The median treatment duration is also an important measure. That means how long do you stay in this drug and how long do you continue this drug? An important thing to remember with this drug is that the response is pretty fast. About 1.8 months from starting the drug, you're going to see a response. And as you can see, the vast majority of patients have continued to receive the drug without any progression. Next slide, please. The toxicity profile of this drug is very, very favorable. About 15% of patients had some kind of adverse events, and the most common significant events that you could see are listed in this slide, and that included fever, low blood counts. But overall, this drug is incredibly well tolerated, and only 2% of the patients on the protocol had to stop the treatment because they had a significant adverse event, something that is also very uncommonly seen when you're trying phase 1 studies or phase 2 studies. Next slide, please. Next slide. Another important thing is that N-Trac inhibitors also have what's called on-target toxicities. That means inhibiting N-Trac 1, N-Trac 2, or N-Trac 3, or Trac A, Trac B, and Trac C also has individual side effects. And some of the side effects that have been attributed to these medicines that are specific to these medicines are weight gain, dizziness, or ataxia. Interestingly, when you stop the drug, some patients have complained of what they call withdrawal pain. They have significant pain, and then numbness when you're giving this medicine. And there has been a panel now that has come up with certain guidelines on how to treat this specific toxicities as seen in this slide. Next slide. Importantly, when pediatric patients were questioned as to whether they had an improvement in quality of life, 75% of children that started larotrectomy had sustained improvements in what they call quality of life, and that was seen by 2 months of starting therapy. Next slide. An important concept of larotrectinib is, can you give this drug prior to doing surgery? And the answer is yes. So this is a series that was reported by Dr. Steve Dubois. And basically there were 5 patients that had what we call infantile fibrosarcomas or other soft tissue sarcomas with an N-Trac fusion that were not resectable initially. And larotrectinib makes surgical resection easier by decreasing the size of the tumor and allowing the surgeon to get a complete response or a complete resection of the tumor with negative margins. Next slide, please. As Dr. Cornelis was saying, there are other N-Trac inhibitors out there. One of them is entrectinib. This one not only targets N-Trac, but also targets 2 other genes, ROS1 and ALK. And there were a couple of patients with infantile fibrosarcoma in this clinical trial, and both responded to the drug. So there are other alternatives, other larotrectinib, such as entrectinib, that could be used for the treatment of N-Trac fusion positive soft tissue sarcomas. Next slide. And like Dr. Van Tilburg mentioned, there are a new generation of N-Trac inhibitors. One is called repotrectinib, and the other one is called selitrectinib. The information out there is still very scant, particularly in pediatric patients. But repotrectinib, approximately 50% of patients that have previously been treated with a TRAC inhibitor responded, and with selitrectinib, for patients that had had a previous acquired resistance to larotrectinib, for example, about 45% of patients responded. So it is nice to know that in the horizon, there are 2nd-generation agents that you could give in the event of resistance to larotrectinib, for example, and patients still have a very good chance of responding to these agents. Next slide, please. There are still a lot of remaining questions on how long to give these drugs, the optimal timing. Do you do this at diagnosis? Do you do this at the time of relapse? For how long? We just heard this story with Leslie that this patient has been receiving over 50 courses of the therapy. When do you continue the therapy after surgical resection? If you take it all out, do you stop or do you keep giving the drug? What are going to be the long-term side effects for this drug, especially since we're giving this to younger patients? Are there going to be long-term side effects 10, 15, 20 years from now? And the answer is we really know. And then what is the best way to treat resistance in this group of patients? Next slide, please. This was a collaborative effort between US and European investigators trying to determine, well, how do you treat an infantile fibrosarcoma? And this is just a small little diagram that tells you that perhaps surgery could be the first incorporation of therapy in these patients. However, if that is not feasible, you can give either chemotherapy or you can give an N-Trac inhibitor. And again, the answer is really not known. And we're going to talk about this in a little bit when we get to the next slide. Next slide, please. So there is currently a clinical study called ADVL1823, and this is a clinical study from the Children's Oncology Group in which patients with infantile fibrosarcoma or other sarcomas of the soft tissue are actually initially treated with larotrectinib. And then depending on your initial response, if you completely take it out, you can observe. If it doesn't respond, you continue to give in cycles of larotrectinib. And this is a study that's going to answer some of the questions that I was posing earlier. Do you give it up front? Is that the right way to do it? What do you do if you resect the tumor? For how long do you continue larotrectinib after you resect the tumor? Or for how long do you continue larotrectinib if the tumor is not completely resected? Again, this clinical trial is ongoing, and hopefully we'll have the answers about this in a few years. Importantly, also, this study is incorporating neurocognitive assessments for these patients, because we know that N-Trac can be affected. So we do not know, again, the long-term effects of these agents 5 or 10 years from now. So this is prospectively being collected in this clinical trial. Next slide, please. So in summary, N-Trac inhibitors are highly active against soft tissue tumors with N-Trac fusions and provide prolonged disease control and extended survival. They have a very favorable safety profile. This highlights the importance of testing N-Trac fusions in pediatric sarcomas. And now there are ongoing studies to assess long-term toxicities and optimal timing and duration of therapy for these patients. And with that, I will stop and I'll be happy to take any questions.
Thank you, Dr. Pappo. A couple of questions have come in. I'm going to jump right in here. First question is, how do you treat the side effects such as withdrawal, pain, and numbness that you mentioned? A panel is addressing this.
Sometimes you can use something like gabapentin. I personally have never encountered that. I know that some of other investigators have, but if you go back to the slide I had, there is a table that tells you exactly what are the potential interventions. So we can go back to that table. And that was developed by an expert panel that was looking specifically at on-target toxicities of these agents. So if you see for withdrawal pain, some people have used COX inhibitors like celecoxib, or some people have used gabapentin. So those are some of the recommendations for this group of patients.
Thank you. Next question that came in is, where are you seeing bone fractures, and is it drug specific? And do you know what's causing the fractures?
I do not know, and I know that this has been an issue with a couple of the N-Trac inhibitors, and perhaps Dr. Van Tilburg will have a better idea. I know that for some of the brain tumor patients, some people thought that it might be a combined effect with the use of steroids with some of these patients. However, I have personally seen a couple of patients with fractures, completely unsuspected fractures on larotrectinib. As a matter of fact, by imaging the right lower extremity, because of the size of these patients, they were young, we included the left lower extremity, and there were 3 fractures in one of the patients, completely unexpected, completely asymptomatic. But I do not know that we know the specifics as to what causes fractures in these patients with N-Trac inhibitors.
Okay, we're gonna do one more question.
Yes.
Do we think fertility for younger children will be affected, and also whether vitamins like multivitamins can be given during N-Trac inhibitor therapy?
I have not seen anything that there's a contraindication to give vitamins. The fertility question, I think it's something that we're going to have to learn and find out many years from now. I don't think that it has been significantly or excessively well studied in this population of patients.
Well, thank you, Dr. Pappo. It was a great talk. I look forward to hearing more from you during the panel discussion. And now we're going to hear from Kaylee, and we're going to hear Ashton's story.
Thanks, Jay. Hello, everybody. I'm really excited to be here today to share Ashton's story with all of you. Our story is actually very similar to Miranda and Hunter's story. Our journey began back about 6 years ago in 2014. Ashton was diagnosed with stage 4 thyroid cancer. This was really rare at the time because he was probably the youngest patient the doctors had seen with such widespread disease. So the cancer had spread from his thyroid to the lymph nodes in his neck and his chest, kind of wrapped around his heart and spread throughout his lungs. So the doctors really had their work cut out for them trying to figure out the best possible treatment plan. And they decided to remove the bulk of the tumors first and then clean up any of the remaining cancer cells with the radioactive iodine. But Ashton, as a baby, he had open heart surgery. So it made it really tricky to open up a second time. And it was just adding to the complexity of the surgery. So we couldn't have surgery at our local hospital. So they sent us across Canada to SickKids in Toronto. And there, because of the extensive disease, they did some genetic testing, just to rule out a hereditary link, which was negative at the time. Once back home, Ashton had the radioactive iodine treatments. He had 2 kind of over the course of a year, and he did really well. Like, our life went back to normal. He was feeling good. And then the winter of 2017, I noticed he didn't have the energy for certain things. At hockey, he would just kind of hang out by the goalie instead of chasing the puck. And he was working harder to breathe. So we brought him back in to see his doctor. And at that point, they realized the cancer in his lungs was starting to change and to progress. And so while we were gearing up for a 3rd radioactive iodine treatment, we got a call from Toronto from SickKids, and they were starting up a new program called the KiTZ. So it was Kids Cancer Sequencing Program. And they asked if we wanted to enroll since they already had samples of Ashton's tumors. And so we signed up. And then the doctors came back to us at that point and said that his cancer was no longer responsive to the radioactive iodine, and that, you know, there wasn't anything else that they could really do. So like Miranda, I started researching, trying to find any possible treatment that would help Ashton. We didn't want to give up hope. And we didn't have to wait very long before we got a call from the KiTZ program saying that they found an N-Trac fusion from Ashton's cancer. So that was really exciting, and that led us right to the drug trial. So in summer of 2017, we started Ashton on the precision medication targeting this specific N-Trac fusion. And for the first 3 months, Ashton underwent like rapid changes. His breathing improved, color improved, he got his energy back. Like he was just a whole nother kid. So it was so exciting for us. And he's been going strong on the trial for 3.5, almost 4 years. So he's living with stable disease right now. I would say the tumors in his lungs have probably shrunk by at least 80%. So that's very exciting for us. And I would just like to say, I think the most challenging part of our journey is just finding support. I know they say thyroid cancer is very treatable, but in Ashton's case and in Hunter's case too, it's been very difficult. It's not the typical case for thyroid cancer. And we had looked really, when Ashton's cancer started to progress, for other families that were like us, that we could relate to, connect with, and just have some support and some advice. And we were just kind of told that there wasn't really any other families like us. So we felt very alone in our journey. And it wasn't until really Susan found us from the NTRKers Facebook group that we felt like we have a community. We felt like we belong somewhere. And it was just really exciting to connect with other people that had kind of similar journeys like us. And I'm just really excited for the NTRKers group because it's just going to provide such an anchor and support for people like us, and hopefully find other people out there that, you know, don't know to do genomic testing or don't know about N-Trac fusion. And I think it's going to be great, lending a hand to future research and, you know, just help patients' well-being. So thank you.
Thank you, Kaylee. Thank you for sharing Ashton's story. We really appreciate it. Our next clinical speaker is Dr. Stephen Wagospack. Dr. Waguespack is a professor of internal medicine and pediatrics at the University of Texas MD Anderson Cancer Center in Houston. He is recognized as one of America's top doctors for cancer and endocrinology. His major clinical and research interests are thyroid cancer, pituitary tumors, and hereditary syndromes of endocrine neoplasia. At MD Anderson, where he has been on faculty since 2002, Dr. Waguespack enjoys providing endocrine care to patients of all ages. With that, I'll turn it over to Dr. Waguespack.
All right, hi everyone, and thank you, Jay. And I must thank Sandra for all of her hard work on behalf of the NTRKers and pediatric patients everywhere with N-Trac fusions, and Miranda and Kaylee for being so brave to share your stories and for advocating for your children. That's really very awesome. Next slide. This is just a disclosure I'd like to present. Next slide. We have to remember, for pediatric thyroid cancer, there are different flavors of thyroid cancer, but the vast majority of cancers diagnosed during childhood will be a type called papillary thyroid carcinoma. And when we speak of N-Trac fusions, we're really speaking of N-Trac fused papillary thyroid carcinoma, although there have been some reports of N-Trac fusions in follicular cancer and poorly differentiated and anaplastic carcinomas. The good news is we don't see those that often in children. So basically we have to keep in mind that these types of cancers will be papillary cancers in children. Next slide. At the beginning, I think it's very important for us to understand overall prognosis as relates to thyroid cancer when diagnosed in children. Unlike other solid tumors, children with metastatic papillary thyroid carcinoma have a very good and long-term prognosis. So here are two studies that just show that. And in both of these studies, what we've learned is that children with stage 2 disease, so stage 2 means the disease has spread to the lungs or elsewhere, do phenomenally well. So long-term survival is very robust and on the order of about 93% or so at 30 years out from diagnosis. Although some children will ultimately die of their thyroid cancer, it's usually not until well into adulthood. So our children diagnosed with extensive papillary cancer, even if it seems very aggressive, actually can live very long with the disease. But in some cases, as we've heard, sometimes those cancers do progress despite standard of care treatment with surgery and radioactive iodine. Next. Similar to other solid tumors, there are various mutational events or molecular events that can happen. And what I want to point out here is in pediatric papillary thyroid carcinoma, we see fusions in the majority of the cases. And so here it shows that fusions in general represent about 50.5% of these cases. The other and more common fusion actually being a fusion in a gene with a gene called RET. Next. If you look specifically at children and young adults with stage 2 papillary carcinoma who've had whose tumors have undergone comprehensive molecular testing, you can see here that N-Trac 1 or 3 fusions occur in about a quarter of those. Next. This has already been covered by the other excellent speakers. Just to highlight the difference between, at least in the US, the 2 FDA-approved N-Trac inhibitors. Some key differences is just how these drugs were developed, so that larotrectinib is approved for any child, and there's an oral solution available, whereas entrectinib has really been studied primarily in adults. That safety and efficacy data was extrapolated to children as young as age 12. Next. This is the entrectinib data. There's not as much data here for thyroid cancer as there is for the other drug. But here you can see in this waterfall plot, there are 4 thyroid cancer patients included. And you can see all of them have had shrinkage of their tumors. Next. And I should mention for entrectinib, because of the way the study was designed, there were no children enrolled with thyroid cancer. So this is the data in thyroid cancer specifically to larotrectinib. And I'd just like you to look at the bars in blue. Those represent the papillary thyroid carcinoma cases. So you can see that with TRK-fused papillary thyroid carcinoma, most tumors have significant responses, whereas others, although they aren't considered to have a partial response, do have some shrinkage in the tumors. And specifically, you can see to the right, there are 4 cases that have had a complete radiographic response. And what that means is that the tumors that were being monitored for change in size actually became undetectable on subsequent imaging. It doesn't mean these patients were cured of their disease, unfortunately, because we still have tumor markers to say that there are still cancer cells there. But I have to point out that Hunter Bowman is one of these on the right. You can see the 2 pediatric patients in this data set both had complete responses in the target lesions. I want to share a couple of cases of my own experience with this drug. So this is a 13-year-old girl with a stage 2. Again, stage 2 implies distant metastases, which will always be to the lungs in papillary carcinoma patients. And she actually had what we call radioactive iodine refractory disease. She had no uptake in her lesions. And I have to mention that I've seen a mixed bag of uptake. You know, it seems like with some TRK-fused papillary cancers, there's good uptake at the outset, but then over time, they lose that ability to concentrate radioactive iodine. In her case, she never had good uptake despite a treatment with high-dose radioactive iodine. But you can see here, just on, as Dr. Pappo mentioned, the responses are very early. So here at 3 months, you can see in these areas highlighted with the circles that she has had significant shrinkage of these pulmonary metastases. I also want to point out that what is typical for pediatric thyroid cancer is that the pulmonary metastatic disease will be large volume but small size. So it's, these are not huge tumors in the lungs typically. Next. This is a 36, you can go back, please. This is a 36-year-old woman with stage 2 papillary. Fascinating, she was diagnosed at age 9, actually treated here way back when in the 1990s. And then I first met her, she had been lost to follow-up. I first met her when she developed a painful bone metastasis in her left jaw, as well as some respiratory symptoms. And you can see here on her PET scan, the disease that was quite avid on the PET scan. Next. So she was found after a good bit of detective work to have an N-Trac fusion. And she was started on an N-Trac inhibitor. And you can see again, within 3 months, she's had a significant PET response. But I want you to appreciate the jaw. There's still uptake there, but one can appreciate that the bone is actually healing there. And she largely became pain-free within 2 to 3 months of starting this. Next. Now, this patient also had evidence of brain metastases, and you can see here, there's a cerebellar metastasis highlighted. Next. And there you can see just 3 months on treatment that it has shrunk. So what this case, I think, has taught me is, one, that we see good bone penetration with these agents, and then also good CNS penetration. So it's very important to know that we have such a good drug that can treat these hard to reach metastatic locations. Interestingly, there's been an interesting thought process that has evolved. This is the concept of taking a patient whose tumor no longer concentrates radioactive iodine and then giving that patient a targeted therapy that then allows radioactive iodine to be reintroduced as a potential treatment for that patient. This is one published example. This was a letter to the New England Journal here on the right that you can see, a 64-year-old woman diagnosed at age 30 who actually had evidence of increased differentiation of the tumor after she took larotrectinib. So this is a very interesting area of thought process and research. Next. So this is our current paradigm of how we treat children with metastatic papillary carcinoma. They first have surgery to facilitate removing the disease in the neck, but also to allow us to give radioactive iodine. We then treat with radioactive iodine, and then we rinse and repeat and do that several times perhaps, or at least that's the old paradigm. And then only when their disease is progressing, despite multiple courses of radioactive iodine, do we consider it radioactive iodine refractory and proceed to kinase inhibitor therapy. Next. This is where I think we're heading in a future paradigm of how to treat these children. Surgery will always be one of the main foundations of how we treat thyroid cancer in children. But now in a child who's diagnosed to have widely metastatic disease, and if they are found to have a molecular alteration such as an N-Trac fusion, I think now we have to consider incorporating targeted therapy up front, perhaps even before we give that first dose of radioactive iodine, with the concept of that, treating a smaller volume of tumor with radiation is going to lead to better long-term outcomes than treating a tumor that has not had a chance to diminish in size due to kinase inhibitor therapy. In papillary carcinoma, of course, our old hammer was radioactive iodine, and we would give it multiple times. And now we have all these new hammers. And for a TRAC fusion positive papillary thyroid carcinoma, we have currently 2 approved N-Trac inhibitors. Next. But to quote Dr. Malcolm here, just because sometimes we can get preoccupied with using a drug that we sometimes don't stop to think as to whether or not we should. And so just because a thyroid cancer has an N-Trac fusion, it doesn't mean that every child with a TRAC fusion positive thyroid cancer needs to go on one of these treatments. So there are still criteria that we need to use and develop as to how to use these treatments in real-time clinical practice. Of course, there's always more questions than answers as we're dealing with novel therapeutics. When to test for an N-Trac fusion in thyroid cancer, when do we actually start treatment with an N-Trac inhibitor, and when do we stop treatment with an N-Trac inhibitor? Theoretically, the longer someone stays on a drug, the more likely there may be to develop a resistance mutation. And I think in pediatric thyroid cancer, where the long-term prognosis is excellent, we really have to think hard about clear stopping points of using these therapies. Of course, we've already heard about resistance and what are the options if the cancer actually progresses on the N-Trac inhibitor. Will another approved N-Trac inhibitor work? Will one of the newer second generation N-Trac inhibitors work? And more importantly, all of us who care for and love our childhood patients, we do have to consider the long-term risks in children. And so, the treatment should never be worse than the disease itself. And I think we have a lot to learn about long-term safety in using this drug in children who don't have immediately life-threatening diseases. So in summary, hopefully I've shown you that PTC in children has an excellent prognosis, even when a child presents with lung metastases. N-Trac fusion genes are prevalent in the pediatric papillary cancer population, and there are 2 effective N-Trac inhibitors available. However, not everyone with an N-Trac fusion actually needs treatment. And it has to be remembered that we often will monitor metastatic disease in young patients with TSH suppression without needing to give them systemic treatments. And certainly more research needs to be done to understand the long-term efficacy and safety of using these drugs in children. And finally, how we might be able to incorporate these inhibitors into the current treatment paradigms. So with that, I'll say thank you.
Thank you very much, Dr. Waguespack. We have time for just a couple of questions, and then we're going to move into the panel discussion where we'll be able to take more questions. If anybody has a question, you can put it into the chat now, and I'm going to start it off with one here. Do you think that treatment with TRAC inhibitors lead tumors to becoming more responsive to other treatments that have failed in the past?
So that's very interesting. So yes, there are some promising, there's promising experience among those of us who treat these types of patients that it may indeed facilitate radioactive iodine therapy in patients with an N-Trac fusion. But of course, this needs to be studied. But as I talked about, that's a very exciting future area of research and better understanding.
So why do you think that N-Trac gene fusions are more frequent in pediatric thyroid cancers than adult?
Very, very interesting question. And we really don't know. I mean, children, so a fusion typically occurs when there's an error in cell division and the DNA kind of getting mixed up in a simplistic fashion. But clearly with pediatric thyroid cancer, we see predominantly fusion events, which we tend to think of occurring primarily, the risk factor for a fusion is radiation exposure, for example. But the vast majority of these children have never had radiation exposure, and they get diagnosed at very young ages. So I'll be interested in what the other panels think, but I don't quite understand why we see such few fusions in adults. But I also think that fusions have a good, probably a better prognostic indicator in children, because adults who have less of gene fusions, they tend to have more of a point mutation in something called BRAF V600E and tend to have more aggressive disease and worse outcomes.
Another question came in. How do you determine which secondary drug needs to be selected if a mutation occurs?
Well, right now we would need to look at clinical trials and see which trials are available to treat. It depends on the age of the patient and what the eligibility of the clinical trials are, but that's how we would determine that at this stage.
So I think we're going to wrap it up with questions there and move into the panel discussion where we'll be able to ask more questions. So I want to thank all of the speakers for doing an amazing job. Welcome you guys back. You can turn your video on, and we're gonna go into some more questions. So jumping right in, I have a couple here. And so I can either direct them or you guys can jump in. I think it would be better if I don't know who it's directed to, then you guys can jump in and whoever's most appropriate to answer. Can an original site of cancer stay stable in disease while taking N-Trac inhibitors, but mutation happens elsewhere? Anybody ever seen that, where another tumor pops up with the original site?
I have personally not seen that, but I guess it potentially could happen, right? It's well known in certain diseases that have been treated with targeted therapies, and although this is not applicable to this, like GISTs, that they initially respond to Gleevec, and then you can have small foci that have developed recurrence that are not sensitive to that. But I have personally not seen that specifically in patients with soft tissue sarcomas that have been treated with N-Trac inhibitors, but I'll ask Steve or Cornelis see if they've seen that.
No, I cannot recall that I've seen it. But I agree with you. It is theoretically possible, I guess. Yes.
So yeah, we do tend to see this more in thyroid cancer in general in adults, not necessarily those on N-Trac inhibitors, because obviously it's such a small group of patients, and of the patients I've had on the trial, I have one adult patient who did develop a resistance mutation after being on a TRK inhibitor for 5+ years. But in general, in thyroid cancer, yes, we can see a secondary mutation occur at a distant metastatic site, and then we'll see differential disease progression where it's progressing in one area and not necessarily in the other area. And then usually we will, if we do molecular testing, we'll find additional molecular events that have occurred in that progressive site.
Another question came in. For the FDA-approved drugs, how would you decide which drug to select, provided both are an approved choice? Is it art or science?
Well, I'll start. I'll put myself out there, I guess. So I have to say, I personally don't have any experience using entrectinib because the trials just weren't set up here to include children. And so, you know, one, I have that experience with the other drug, larotrectinib, but also if you look, I think we have more safety data with larotrectinib in children, whereas entrectinib, the safety data is extrapolated from the adult experience. And so, you know, I tend to favor larotrectinib mostly because we have more data in terms of safety, but I'll be interested in other people's thoughts.
In the beginning, when there were clinical trials for the two drugs, we basically went by availability of clinical trials. It's interesting that the solid tumor team here opened the larotrectinib trial and the brain tumor team opened entrectinib. So they treated their N-Trac fusion positive brain tumors with entrectinib, and we treated our soft tissue tumors with larotrectinib. Then the pediatric match clinical trial opened, and now they have larotrectinib available. We're also participating on a real world experience trial with larotrectinib called On-Track. And I think, like Stephen said, I use mostly larotrectinib and I feel extremely comfortable using it. So just because of that, that would be my drug of choice. But it's really, that's the only reason.
I think this is a good follow-up question to that came in, and it's what is your feedback from the first patients treated with larotrectinib about 10 years ago, and what are your conclusions based on the safety of on those feedback?
So I don't have feedback from patients from so long ago, and I'm not sure that my colleagues do have such a long follow-up.
Well, I think that the trials started, what, 6-7 years ago? It hasn't been that long. Yeah, my experience is just that the one, at least from thyroid cancer, the one patient who was on it 5+ years, who did phenomenally well. So I'm not sure what feedback you're thinking of, whether it's symptoms or long-term issues. But he did very well and is now on a second generation NTRK inhibitor with a great clinical response. But the second generation inhibitors we didn't really touch on, but have more neurologic side effects.
So another question that came in early before the webinar was, how early should children with cancer be tested for N-Trac gene fusions, or in fact any genomic cancer driver? I guess if money's not a factor, early, right?
Yeah, if money's not a factor, it's early indeed. So I can give you a European perspective. I already said that in the brain tumors, pediatric brain tumors, I think that for many reasons, patients should be tested soon, and possibly a primary diagnosis already. But that doesn't have to be a full gene RNA sequencing, because most of the time, if you find the usual oncogenic driver for the respective tumor, there will not be an N-Trac fusion probably. And this more or less also holds true for many solid tumors, where Alberto is much more experienced in. But so if you have the tumor with its normal driver, I don't think you need to do extra N-Trac testing, so to say. But at this moment, we test all brain tumors, and high risk or relapsed solid tumors also get whole genome testing. So we will always find the N-Trac fusion.
And many centers are routinely doing now, sequencing of all patients. I mean, we do that here with all of our patients, even if it's not a specific indication. Everybody will get at least exome and RNA-seq here. So you'll have that information. For soft tissue tumors, I think that anytime you have a soft tissue tumor that has recurred several times, especially with age younger than, let's say, 5 years of age, I think that N-Trac should be screened for. And also there's an emerging number of other targets like RET, etc. So I think it's worthwhile doing that. And for the most common ones, like mammary analog secretory carcinoma, thyroid, infantile thyroid definitely that should be done almost immediately after the initial diagnosis, in my opinion.
For thyroid, I tend to, anybody with lung metastases or other distant metastatic disease, I do like to do fusion testing up front, and not because they actually need treatment right away, because as I told you, we can sometimes watch for decades without needing to do anything. But I call it getting to know the enemy better and having that information so that when that child is 20, 30, 40 years old and they might need treatment, we actually already know what's driving their tumor. And the reason why that's important too, at least for thyroid cancer, is that, as was mentioned before, RNA sequencing is the most sensitive way to identify N-Trac fusions. And over time, RNA degrades from the primary tumors. So I do feel there's value with stage 2 disease doing it, or in someone presenting with a very locally invasive primary tumor where we might consider a treatment, a neoadjuvant approach treatment before primary surgery.
I think here at Alex's Lemonade, we're seeing standard of care for genomic sequencing at big centers, not necessarily at small regional hospitals yet. So I think there's not a one standard across all the country yet. Another question came in with regard specifically to pediatric glioma. Are there any known interactions between N-Trac inhibitors and other medications that a brain tumor patient might be taking, for example, anti-epilepsy medication?
I can answer that. So I don't have a specific answer here. Anti-epileptic medication in general is known to have many interactions, and it can well be that it can have interactions with N-Trac inhibitors. So you need to have a specific look at which drugs you're talking about. But I'm quite confident that if you look at it and maybe with the help of hospital pharmacist, you will find a way in combining most of the drugs. So I'm not really worried there, but it's an important point, and you need to be aware of it. But I don't think that will be a reason to not treat a patient or something.
This person had an interesting question. Are there benefits to stopping and starting N-Trac TRK inhibitor medications again, and what is the evidence to support this if it is better to start and stop them?
I think it depends on the clinical scenario. We heard from Leslie what happened. I've had a couple of patients with very similar situations. The tumor got extremely small. We went in, did surgery, had positive margins, and then we watched it and it came back and then restarted it. And I've had some patients that have been on the drug for a while, and you're given what you call a drug holiday, and I've been successful in doing that in one patient, and the tumor has not come back, but in a couple of others, the tumor has regrown and I have to restart it. But I don't know if there is a specific rationale to go in and out to try to resensitize the tumor, like some people have said to do that, for example, in melanoma. I don't know that there is a specific rationale for doing that, but I would be very interested to know what Steve and Cornelis have to say about that.
So I have the same experience as you have. So sometimes you would try to pause the drug and you're successful and you can leave the drug out, and sometimes not. But I also think this is not it's not a reason to to really propagate a on-off regimen or something like that. We will go there.
I think the one area that might be helpful is in thyroid cancer, because it's such and generally a more indolent disease, and we don't, we haven't gotten a lot of experience yet, obviously, stopping NTRK inhibitors in patients on them. But in general, I don't know if the disease was not rapidly progressive before starting an NTRK inhibitor, it probably will grow after you stop it, but probably still at a slow rate that we could watch for a few years. So, I think that is something we do need to consider, at least for thyroid cancer patients, is, do we treat for 1 or 2 years to maximum response and then give it a holiday and then re-challenge them later if their disease is progressing? And my experience with other children that have not been treated with NTRK inhibitors is that sometimes we see a period of progression, particularly during adolescence, and then that settles down. So I have several 20, 30-year-old patients in my practice we've been watching their distant disease for quite some time now without significant progression, even though they required kinase inhibitor therapy during childhood. The other reason you'd consider this kind of on-off approach is if someone's having poor tolerance, but fortunately, most patients can tolerate this drug, but at least other drugs we use in thyroid cancer, we sometimes build in holidays to minimize the toxicities.
So I think we have time for one more question. And question I have here is, can mutations other than N-Trac affect treatment choice? And does this depend on the tumor type?
So I can briefly comment on that. We didn't do that so far. But in the adult world, there's a little bit more known. And there's sometimes during treatment with NTRK inhibitors, you can also see the occurrence of other mutations or alterations. And they have started in treating patients with not only NTRK inhibitor, but also in combination with other inhibitors of specific targets. That's I think we are in the beginning there. I'm not aware that there is now systematic data out there where you get a good feeling about if it's useful, whether it's active. I assume that it has a good chance. And I'm not aware that we did see a lot of those things happen in children, but it can also be that we don't have enough follow-up time behind us before these things occur. But I'm curious whether my colleagues have more experience in this.
I agree. I don't have additional comments. I agree.
Well, thank you this has been an amazing webinar. I learned a lot from your talks and from answering the questions, and I hope that everybody who joined us learned a lot. And with that, I am going to turn it back over to Susan to wrap things up. So, there you go,
Yeah.
Susan.
Thank you. Thanks, Jay. And I want to thank everyone for attending today. And thank you to all our speakers, wonderful speakers today who all volunteered his or her time to make this webinar happen. And this is going to be recorded, and the link will be posted on our website, NTRKers.org. And we're also going to send out a survey via email. I would appreciate any feedback. Specifically, if there's any information, support, or resources that the N-Trackers can provide to help you and your families, please make sure you provide that feedback on that survey. And then remember, you can find us at ntrackers.org. You can email us at info@ntrackers. We're also on Twitter and on Facebook. And I just want to thank you again for attending. And for our wonderful speakers, and I'm wishing everybody to have a wonderful and safe day as well. Thank you very much.
Thank you for the invitation. Thank you.
Sure.
Thank you. It was a pleasure.